Hi, my name is Baraka Muvuka. I'm currently a second-year doctoral student in health promotion and behavioral sciences at the University of Louisville School of Public Health and Information Sciences. I'm also a graduate assistant at the Commonwealth Institute of Kentucky, where I'm part of a team that's led by Dr. Ryan Combs, and our team works to improve health literacy in the West Louisville community through community-university partnerships, some of which I'll be presenting today. So this presentation is entitled Addressing Health Literacy in African American Communities. This is a relevant issue given the complexity of the healthcare system and the constantly changing healthcare environment or landscape. Health literacy is crucial for individuals to navigate this complex and frequently changing healthcare environment and for individuals to remain healthy. And so, in this session, I will begin with an overview of health literacy, discussing its definition, the different types of health literacy, how it is measured, and who is affected. Next, I will briefly discuss why health literacy is a public health issue. We will then delve deeper into looking at health literacy among African Americans, and in this section, I will be presenting results of a literature review that we conducted to identify some barriers to health literacy among African Americans. Lastly, I will present some evidence-based strategies to address health literacy among African Americans, ending with some examples of local health literacy efforts conducted by our team in partnership with the West Louisville community. In terms of learning objectives, by the end of this session, you will be able to provide a comprehensive definition of health literacy. You will also be able to explain why health literacy is a public health issue. You will be able to describe barriers to health literacy among African Americans, and you'll also be able to discuss some strategies to address health literacy in African American populations. Without further ado, let's start with the definition of health literacy. What is health literacy? So, in its 2004 publication on health literacy, the Institute of Medicine defined health literacy as the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services needed to make appropriate health decisions. Since then, this definition has been the standard definition used by several agencies. And you will notice that the bolded words obtain, communicate, process, and understand, and even the word make appropriate health decisions, that all of these words imply that individuals are expected to act on health information. They're not simply expected to receive this health information, but also to process and understand it so they can make healthcare related decisions based on the information that they receive. Health literacy is an umbrella term with so many different subtypes. Here, we are only going to discuss 3 important types of health literacy that are relevant to the work that we do in West Louisville. So we have health behaviors literacy, health insurance literacy, and health systems literacy. Health behaviors literacy, it refers to an individual's ability to obtain, process, and understand health information that is related to particular health conditions, and to be able to utilize this information to perform behaviors that are recommended by health professionals or public health professionals. And so the next slide, this slide presents an example of health behaviors literacy. It clearly depicts a problem with health behaviors literacy. For example, people with limited health behaviors literacy may have trouble understanding their prescriptions. And as a result, you will see that only 25 to 30% of prescriptions that are taken properly. Individuals with limited health behaviors literacy may also have trouble knowing when or where to get their prescriptions refilled as prescribed. So in this example here, out of 100 prescriptions that are issued by a provider, only 15 to 20 are refilled as prescribed. And this can have serious health implications, especially among individuals who have serious or chronic health conditions and are expected to take their medications on a regular basis. Now, health insurance literacy is very common, so it refers to an individual's knowledge, ability, and confidence to find and evaluate information about health plans, to select the best plan for their own use or for their family's financial and health circumstances, and to be able to use the plan once enrolled. It is important to note here that being able to select a health insurance plan or to even have coverage does not necessarily translate into being able to use it. Research shows that even individuals with health insurance may underutilize their benefits because they may not simply understand it, or they may not know where to look for information about the services that they need. And so that becomes a serious issue, especially considering that health insurance is a complicated system here in the United States. Next, health systems literacy refers to a consumer's ability to understand the different levels of care. This can be self-care, primary care, urgent care, and emergency care. And it also is concerned with the different ways in which to access services and to utilize this information to navigate the healthcare system. Now, this slide depicts a great example of health systems literacy. It provides information, as you can see, on the different types of care and when to seek such care. For example, individuals with limited health systems literacy may not know that they can actually go to a primary care physician for certain conditions instead of going to the emergency room. And as a result, reports have shown increased emergency room utilization in cases that were even non-emergency. And this leads to increased healthcare spending. So this is an issue with health systems literacy. Now, let's look at the different factors that influence health literacy. Evidence suggests that health literacy is influenced by a variety of factors at the individual and systemic level, as depicted in this diagram. So this diagram is adapted from the CDC. Here, they use the term public health literacy, which is another way of referring to health literacy, but in the public health domain. Based on evidence from several studies we have reviewed, I added the social determinants box that you see on the left side of this diagram, as social determinants are powerful predictors of access to health resources, as I will be explaining shortly. Now, going back to the model, this model shows that individual characteristics such as knowledge, skills, education levels, income, values and beliefs, along with experiences with the healthcare system, that these factors affect the way in which people understand and use health information. For example, an individual may need basic math knowledge to be able to calculate the amount of calories in their sandwich, or to even be able to calculate their health insurance costs. What about knowing what hypertension and sodium stand for? Individuals may need some level of health or nutrition knowledge, or better yet, deductibles versus copays and premiums. This requires some level of health insurance knowledge and experience. I'm pretty sure you can think of many more examples of individual characteristics that influence health literacy. Culture is also a significant factor that affects how people communicate, understand, and respond to health information. Secondly, the right side of the model depicts healthcare system factors that influence health literacy. At the public health practice level, these include the way we communicate and disseminate health information, the complexity of health information, the suitability, cultural and linguistic suitability of health information, and the dissemination channels for health information are important predictors of health literacy. In terms of health infrastructure, this includes whether or not we have services that are sensitive to individuals' health literacy levels and whether we provide health literacy support or resources in our institutions. The communication skills of healthcare professionals also matter. For instance, medical terms or jargon may not be very well understood by individuals with limited health literacy. Now, let's look at the social determinants of health box that's on the left side of the model. These are the factors that shape the social and physical conditions in which we are born, grow, live, learn, work, play, and age. Such factors include socioeconomic status or economic stability as it is shown in the model, education, employment, physical environment, neighborhood conditions, social support, or even access to healthcare. As you will see later in this presentation, the inequitable access to education, income, and employment affect our access to the resources that are needed for us to develop the skills and knowledge related to health literacy. They also affect access to health literacy support and resources. All of these factors that we've discussed shape how individuals function within the often complex healthcare context, and so they all influence health literacy. Now, next we're going to discuss how health literacy is measured. There is no clear or no consensus yet on how health literacy should be measured. Researchers have used various tools, the most common of which are the tools that are listed on this slide: Rapid Estimate of Adult Literacy in Medicine, or REALM, and Test of Functional Health Literacy, the newest vital signs. So there are many versions of these tools as well. There can be the short versions and the longer versions of these tools. English and Spanish versions are the most commonly available. These tools measure reading and comprehension of health-related terms and instructions. They also have they measure quantitative or numeracy skills, such as calculating drug dosages or calculating health insurance costs based on the information given. They also measure problem-solving and decision-making skills by providing scenario-based tasks. The 2003 National Assessment of Adult Literacy is the most recent national survey with a health literacy component. The survey measured health literacy by directly assessing individuals' completion of health tasks in the following domains of healthcare: in the clinical, prevention, and navigation of the healthcare system domain. Example of tasks in the clinical domain included filling out forms or understanding dosing instructions. In the prevention domain, they measured individuals' ability or the extent to which individuals were able to follow the guidelines for age-appropriate preventive services based on the information that was given to them. They also measured participants' ability to identify signs and symptoms. In terms of navigation of the healthcare system, tasks included determining what a health insurance plan will or will not pay for based on information given. Depending on individuals' performance on these tasks or on the surveys, participants were classified as having below basic health literacy, basic, intermediate, or proficient health literacy. So at the proficient level of health literacy, individuals could perform complex and challenging activities. Individuals with proficient health literacy could calculate share of health insurance costs, and they could make sense of complex documents, actually. This is the ideal level considering the complexity of our health care system. Individuals with intermediate health literacy could perform moderately challenging literacy activities such as understanding information presented in charts or graphs, so making sense of information presented in graphical forms. Individuals with basic health literacy were found to be limited to simple everyday literacy activities such as deciphering basic information from short pamphlets or one-page brochures. Lastly, individuals with below basic literacy performed no more than the most simple and concrete health literacy activities, such as circling the time and date of a medical appointment on an appointment slip. Now you will ask, who is most affected by health literacy? The first chart on your left shows the overall literacy levels of Americans. As depicted, only 12% of American adults have proficient health literacy, and that versus 14% of individuals who have below basic health literacy. In other words, nearly 9 out of 10 adults, or 191 million Americans, may lack the skills needed to manage their health and to prevent disease. While limited health literacy is an issue among most Americans, certain groups bear a higher burden than others. The chart on the right side shows that white and Asian or Pacific Islanders adults have higher average health literacy levels than Black, Hispanic, American Indian, Alaska Native, and multiracial adults. Hispanics and African Americans were particularly overrepresented on the lower end of the health literacy scale, that means below basic and basic, and yet they were the most underrepresented on the higher end of the health literacy scale at the proficient health literacy levels. For example, you can see that only 2% of African Americans and 4% of Hispanics had proficient health literacy compared to 18% of Asian or Pacific Islanders and 14% of white. In addition to racial or ethnic minorities, older Americans who are aged 65 years and above are more susceptible to low health literacy compared to younger Americans, partly due to some physiologic or cognitive changes that start taking place in the later years, for example, changes in vision and changes in hearing. So this can affect health literacy. Individuals with lower educational attainment, particularly those with less than a high school diploma or GED, tend to have lower health literacy scores because education provides individuals with the cognitive or information processing skills that may be transferable to health-related tasks. Similarly, individuals living below the poverty level have also been shown to have lower health literacy, often due to lower educational attainment, but also to poor access to resources needed to develop health literacy skills. Individuals with limited English proficiency may have trouble understanding and utilizing health information presented in English and complex language. While an often forgotten group in the health literacy research, individuals with developmental or intellectual abilities may also experience difficulty understanding or processing complex health information. So we have discussed what health literacy is, how it is measured, and who is affected. Now, the next question is, why is health literacy a public health issue? Health literacy is a public health issue because it is associated with lower knowledge of health conditions and treatments or recommended regimen, difficulty navigating the healthcare system, difficulty performing health-related tasks, lower utilization of preventive health services or screenings, leading to otherwise preventable hospitalizations, poor health, such as chronic conditions, health disparities, inadequate access to healthcare, higher levels of healthcare spending from preventable hospitalizations. So the U.S. spends an additional $29 billion each year as a result of low or limited health literacy. Really, simply put, Low health literacy leads to higher emergency room utilization, more hospital stays, less compliance with treatment plans, more deaths, and poor quality of life. And this is why limited health literacy is a public health issue. Now, this second part of today's presentation looks more specifically into health literacy in African American communities and some strategies to improve health literacy in these communities. Without further ado, we conducted a literature review or literature search on several databases and found limited studies on health literacy among African Americans. Available studies either did not include African Americans, or even if they had African Americans in their sample, they did not report these findings by race or ethnicity, or some of them were actually condition specific. And all of this left us with just 19 studies for our review. We found that there were multiple factors contributing to limited health literacy among African Americans, which we categorized into the following four overarching themes. We found that socioeconomic factors influence health literacy levels among African Americans, inequitable social structures, complexity of the healthcare system or healthcare system factors, and approaches to health information delivery, lack of tailored health information delivery approaches. And so, with regards to socioeconomic factors, most studies reported that income and education affected health literacy levels, inequitable levels of income and education. So, for example, with regards to income, both individual and collective economic resources are necessary to obtain health-related goods and services, including those related to health literacy. Now, studies found that poverty limited the availability of resources needed to understand and to access health information or even essential health services. Other studies found that individuals with low income often had trouble accessing healthcare resources, often due to perceived cost or of care, lack of insurance, and even transportation issues. Yet reports have consistently shown that a large proportion of African Americans are still living below the poverty level and are more likely to have lower healthcare seeking behaviors and limited interactions with the healthcare system. All of these exacerbate health literacy levels as health providers or individuals working in the healthcare system are found to be one of the main sources of health related information or of health. They are found to largely be main sources of information in African American communities. With regards to education, the relationship between race or ethnicity and health literacy was mediated by differences in educational opportunities. Education has been reported to improve health literacy and health outcomes by increasing knowledge levels, cognitive processing skills, and trust of health information. Yet African Americans have been shown to have lower educational attainment than other racial or ethnic groups. This stems from inequitable practices and policies that have systematically limited their access to quality education. This leads us to the discussion of inequitable structures, social structures, which is the next important theme. In terms of inequitable social structures, we found that these inequitable practices and policies have perpetuated mistrust of healthcare providers in the African American community. According to some studies, African Americans are less likely than other racial or ethnic groups to trust medical establishments due to negative past experiences and perceived mistreatment by healthcare providers and the healthcare system. Some of these include abuses of African Americans during the Tuskegee syphilis experiments, which ran between 1932 and 1972, or even due to differences in disease prevention and treatment-related beliefs between patients and healthcare providers could also contribute to the mistrust of healthcare providers. The mistrust of healthcare systems affects perceptions of the credibility of health information and also influence health-related decision making in the African American community. Another factor that was under those inequitable social structures was racial discrimination and residential segregation. A notable finding was that social-cultural factors and social structures influence health literacy. Due to the systematic exclusion from power, socioeconomic, and structural resources, African Americans are more vulnerable to health inequities. They're also vulnerable to low-quality healthcare and even to limited health literacy compared to other racial or ethnic groups. Racial discrimination and residential segregation were reported to create disparities in educational opportunities, thus limiting the development of knowledge and skills that are needed for health literacy among members of racial or ethnic minorities, particularly African Americans. Next is the complexity of the healthcare system. We found that there is a mismatch between the demands of the healthcare system and consumers' health literacy levels. Navigating the complex healthcare system is particularly challenging for individuals with limited literacy, and we've already seen previously that African Americans tend to have lower health literacy. So navigating this system becomes particularly challenging for them as it requires additional skills. Then we have lack of tailored health information delivery approaches. Evidence suggests that health information is not adequately tailored to meet the specific health literacy needs of African Americans. Additionally, African Americans are often lumped into one group, and yet they have diverse cultural values and beliefs. Traditional print materials that are used by healthcare organizations or even health insurance companies, such as brochures that are written in medical jargon, are not well received, especially among individuals with limited health literacy. Now, in this section, I will be presenting some evidence-based strategies to improve health literacy in African American communities. Part of this comes from our literature reviews and others from our studies that we are conducting in West Louisville. In our literature review, we looked at what has worked in other African communities and found that the methods listed on these slides have been more effective in reaching individuals with limited health literacy. With respect to tailored messaging, we found that African Americans prefer information that is culturally tailored, relevant, acceptable, and useful. This was best achieved by partnering with African American communities to develop appropriate health literacy interventions. Television, radio, and the internet were preferred sources of health information among a large number of African Americans, as shown in some studies. Messages disseminated on the radio were more effective when they were broadcasted on radio stations or channels with large African American audiences. So such channels included gospel stations or hip-hop music stations for younger populations. While internet utilization was less common in older adults, older African American adults in some studies expressed greater interest in internet use compared to non-Hispanic whites. However, technology should be used with caution since this requires individuals to possess additional computer literacy skills. Booklets with graphics. While printing materials were not commonly cited among the preferred health information delivery methods, print materials were deemed useful and easy to understand when they contained less text, more culturally appropriate visuals, real-life stories, and practical or action-oriented steps that were easy to digest. Materials developed in partnership with African American communities were often more effective, and they ended up being more relevant and culturally appropriate when they had community input. In terms of storytelling slideshows, for presentations, this can be appropriate. Slideshows that told stories and contained images were found to be effective in improving health literacy about high blood pressure and diabetes among African American participants in some community-based participatory research studies. The teach-back method, in the clinical setting, the teach-back method, which assesses comprehension by asking a patient to restate key information discussed by a healthcare provider, has been reported to improve knowledge when used in a non-threatening environment, as it enables immediate clarification. In summary, reaching African American communities more effectively may rely in part on adopting novel approaches to health information delivery developed in partnership with the target audience. Ultimately, sustainable improvements in health literacy among African Americans will require undoing the very practices and policies that have systematically excluded them from accessing essential resources needed to develop health literacy skills. This entails addressing the social determinants of health, such as providing access to quality education, creating more integrated neighborhoods that provide individuals with equitable access to quality education, equitable access to employment opportunities, and access to health literacy resources. We also need to revisit our healthcare practices and policies to ensure that they are designed in such a way that they cater to consumers' health literacy needs. These last few slides provide examples on two ongoing health literacy projects in West Louisville that are currently being implemented by a team from the University of Louisville School of Public Health, working under the Commonwealth Institute of Kentucky, in partnership with the West Louisville community and several other stakeholders, including the Louisville Metro Department of Public Health and Wellness. Just to provide a little bit of background on West Louisville, it is home to over 60,000 individuals, 78% of whom are African American. West Louisville is made up of 9 neighborhoods that are depicted on the map on the right side. Now, we chose to intervene in West Louisville given the social and health disparities or inequities it faces. For example, a poverty rate 3 times that of Louisville Metro and higher mortality rates than the rest of Louisville Metro. All of these are predictors of limited health literacy, as already discussed in the earlier sections. Our health literacy efforts aim to enhance residents' ability to access available resources to prevent and manage chronic conditions and to maintain positive health. The first example is a recently completed research project on health insurance and health systems literacy in West Louisville. This project was conducted to understand residents' health insurance and health systems literacy needs and to get their insights on a culturally appropriate intervention to assist them to navigate the healthcare system and to utilize health coverage. We conducted a total of 12 focus groups in 2 rounds with 87 West Louisville residents of California, Russell, Parkland, and Shawnee neighborhoods. 4 focus groups were age-specific, with residents under 30 years old and residents over 65 years old. The first round of focus groups explored participants' experiences with health insurance by asking, what are the issues? And round 2 examined their health information delivery preferences. We found the following themes. Round 1 participants revealed the complexity of the health insurance system, with many citing difficulty understanding health insurance concepts such as premiums and deductibles, and others having difficulty finding suitable healthcare providers. High costs, mistrust in the healthcare system, and perceived disparities in public-private insurance were barriers to effective health insurance utilization among participants, focus group participants. Now, building on round 1 findings, Round 2 participants recommended an intervention involving culturally competent personal navigators rather than traditional methods such as bulky print materials, bulky brochures, or call centers, automated calls. They wanted navigators, in-person assistants, or navigators who are neutral, meaning not employed by a health insurance company. They wanted somebody who has knowledge about health insurance and about the community and its culture. They preferred somebody from the community. They also wanted somebody who has time. This is similar to the ideas of connectors. The second example is that of a community-based participatory research project that uses the bootcamp translation methodology that I will be explaining subsequently. Our traditional approaches to research and designing interventions has been one that considered us as professionals and academics as experts and considers community members as the ones in need. While we may have the academic or professional resources and expertise, without involving the community, we end up aiming at the wrong target as shown in the picture on the left. This simply means we should always strive to collaborate with the community to identify and address issues that are relevant to them because they are the experts of their own community and their own cultures and their own experiences. The second picture on the right depicts that with community engagement, we are able to address issues that are relevant and of priority importance to the community. This is exactly what the bootcamp translation method is all about. The problem is that everyday people often can't understand academic or research language about health. So why not translate the jargon into locally relevant, meaningful, and engaging messages that the community members can understand? Bootcamp translation is a novel community-based participatory research approach that was developed by Dr. Westphal and a team in rural Colorado. In bootcamp translation, a team consisting of an equitable number of community members, academics, health professionals, and medical experts work together over a period of usually 6 to 12 months to learn about a specific condition and to answer two main questions. What do we want people in the community to know? And the second question is, how do we effectively share that information in a locally relevant manner? In our projects in West Louisville, our teams consist of 1/3 community members, 1/3 academics, 1/3 health professionals, and a medical expert. We strive to maintain that balance. During the first meeting, which is a day-long meeting, a medical expert presents evidence on a selected health condition, after which the team brainstorms to identify relevant messages and the target audience. Over the next months, the team continues to meet in person or by conference call to refine the key messages, the actions that they want people to take, and to create an appropriate intervention. Now, our team used the bootcamp translation method to design a health communication campaign that we called Depression is Real. This campaign targeted adult African Americans living in West Louisville and who are suffering from depression. As a result, we developed 4 key messages. First message was that depression is real. The second message is you are not alone. The next message is there are options to get better. And the last message was, you do not have to suffer. Our call to action was to call 211, a number they would call to get referred to culturally appropriate mental or behavioral health providers that we had partnered with in the community. Prior to the campaign, we met with mental health providers in the community to ensure that they had culturally competent therapists. We designed flyers and posters which we posted in community centers, beauty shops, barber shops, and the public bus system, the TARC. We also had radio ads, a radio call-in show on gospel stations, And we organized a grocery outreach with giveaway products that had our logo. Finally, we had dinner with church leaders to talk about our campaign so they can help us disseminate these messages to their congregations. While evaluation is still ongoing, early evidence suggests we had a wide reach through these various channels. This is an example of a poster that we developed specifically for men. Notice the title or slogan, "Depression is Real," and the messages and the call to action. We had several other posters for different target audiences. So what's the bottom line? Here are key takeaway points to conclude this presentation. We have to engage communities in identifying and addressing their unique health literacy needs. As public health professionals, we need to tailor health information to individuals' needs, preferences, and cultures. There is also a need for additional research and development of innovative health information delivery strategies in partnership with the community. We have to serve as advocates for policies that address the root causes or structural factors that contribute to limited health literacy or inequities in health literacy levels. I would like to thank my colleagues in the Health Literacy Research Team. For more information about the health literacy projects in West Louisville, you may contact Dr. Ryan Combs, who's the primary investigator of this project, at ryan.combs@louisville.edu, or you may contact him by phone at 502-852-1995. Thank you for your time.